Hello, my name is Alison Porter from Swansea University, and I would like to tell you about the TRIM study, which we are coming towards the end of. It's a project looking at the response of ambulance services, emergency ambulance services across the UK to the COVID-19 pandemic. And I'm going to focus on one particular aspect of it, a qualitative study which was embedded within the larger evaluation, which looked at what it was like for the staff in emergency ambulance services having to make that response to the pandemic and in particular implement some changes in practice to try and help ambulance services cope. And as they told us, every day was a learning curve. So the TRIM study, the larger TRIM study, is an evaluation of the models which were introduced to triage and manage emergency ambulance service care during the COVID-19 pandemic. Obviously, ambulance services had to find a way to cope appropriately and safely with these additional demands that were based on them without compromising the quality of patient care. And we're focusing in particular on the early phase of the pandemic, spring and summer 2020. So that's a large-scale study using routine data. Within it is a qualitative component. So it's aiming to understand the experiences, concerns of clinical and managerial staff about this response. And for this, we focused on 4 case study ambulance services across the UK, or specifically across England. And as part of this, we conducted qualitative interviews, 25 altogether across these 4 sites, which were done by research paramedics who were embedded within the services, so people who actually worked for the particular ambulance services. And we transcribed the interviews and conducted a thematic analysis, input from the research team, including the research paramedics, and also some marvellous public participation partners we have. Just to clarify for you, those of you who maybe aren't that familiar with the way emergency ambulance services work, this is a slightly simplified model, but you could identify really 3 key points of decision making where the ambulance service has to decide what to do in response to a 999 call. So first of all, in the emergency operations centre, the call centre, there will be a call handler. The first person you speak to would not be clinically trained. They basically be using algorithm software to guide them through a series of set questions to find out from the caller what the needs are, and then make a decision about what needs to be done. So very importantly, in response to the pandemic, they were wanting to identify as soon as possible those patients with suspected COVID-19 so that they could decide an appropriate response, which would include whether or not to send an ambulance, speed of response, and also what maybe protective measures the crews needed to take. There are a number of, 2 main software systems which ambulance services use to help them categorize calls and select priority. One of them was used more widely, is called AMPDS, and within that there was a specific protocol introduced, a pandemic protocol called CARD 36, which would help to influence practice and what to do. So then there could be, in certain cases, if the call handler thought it was appropriate and wanted to call in additional help, there could be further triage within the call centre. So this would likely be a clinical person. It might be a specialist paramedic, a doctor or a nurse, someone who would talk to the caller, whether it's the patient or a family member on the phone. They'd be able to bring in additional clinical judgment in order to decide what to do, and may also have specialist triage tools to call on. So all that's happened, an ambulance goes out, and then of course there's another stage of decision making at scene where the paramedics, the crew members of the ambulance are looking at the patient, deciding what to do. Again, clinical judgment plays a part, but there may also be specialist protocols they're following. They may have particular referral pathways introduced in response to the pandemic, guiding them where to send the patient. And they all may also call on remote advice. They may call back to base and ask to speak to a more senior person, a doctor, someone to give clinical advice. So at all of these points of decision making, which are always there, particular tweaks and adjustments were made in response to the pandemic. Changes in process, protocol, additional resources put in, slightly altered roles for certain clinical professionals, and so on. So for those people who were having to put all this in place, what did it feel like? That's what we were interested in finding out. Well, first of all, you won't be surprised to hear there were a lot of people talking about how stretched the system was. An increase in total demand, but not in a simple way. Real peaks and troughs, and particularly very much in the early days, actually reduction in calls initially. People were cautious about making the call into the system. But then that soon got overtaken by peaks of demand. Also a difference in the mix of the patients coming through. So more high acuity patients, more needy people, fewer of the people who really didn't need an ambulance. At the same time, what was available was more stretched. Staff being off sick or isolating because a family member had COVID, reduced the resources that the service had to send out, and also increased job times. Each patient was taking longer because of the PPE that the clinicians had to put on and take off, additional cleaning of the ambulances, and so on. So in short, it left a situation where sometimes the staff were feeling desperately stretched. It got to a stage where if you had a swear box on the dash, it would be overflowing before the end of a shift. You know, it's not again kind of thing. Here we go. And it just grinds you down, or ground me down, because it's just repeats. Secondly, I talked about some of the tweaks and the changes in the processes people had to follow, but these were constantly changing as more information emerged. And especially in the early days, there was very rapid change. So sometimes even many times a day, different instructions were coming out. So this is work for the managers who had to sort of form and implement them. Services would learn from each other. They'd also refer to national bodies for guidance. But it was also work for the other members of staff to keep themselves up to speed with all these changes. So every day was a learning curve, as the dispatcher in the EOC said. Every day something new would slightly change. Something else which staff of all groups talked about was the importance of thinking about the ambulance service as part of the wider healthcare system. It wasn't just down to the service in isolation choosing how to respond, but actually there was impact going on from changes in other parts of the healthcare system. And many of them talked about how emergency ambulances became a kind of default option as other doors closed or were seen to be closing, particularly primary care. There were also more calls coming into the system via urgent care. So patients or families would call NHS 111, who were very, very cautious and using a protocol-driven system, were sending a higher proportion of calls to the ambulance service than they normally would. There was also impact on the service from what was going on in hospitals. As hospitals became busier, delays with patient handover built up, the ambulances queuing outside the hospital, and so on. So as one senior manager said about the impact on the system as a whole, we had patients just leaping around the system with nobody opening their doors to them, apart from the poor paramedics out there who were having to deal with this mess caused by, closing down services. And the staff also talked a lot about the emotional load of responding to the pandemic, the impact it had on them as individuals. Now, obviously, this isn't, a change in protocol or procedure, but this was the reality of the situation they were in having to deliver that professional response. As human beings, they were dealing with the burden of the workload pressure, the demands of the work itself, The exposure to the patients and families to stress, a lot of extremely anxious people calling in or dealing with a lot more death than may normally happen. Anxiety about colleagues who were ill. All ambulance services lost members of staff. Sometimes it was more than just being ill. And also the fear of taking the infection home, even for patient-facing staff, but even for people in the emergency call centre as well. So as one said, I was coming home and standing in the corridor, taking my uniform off and running in the shower and sobbing my heart out, day after day after day. But overall, people from the services felt they were doing the best they could in the face of uncertainty and this rapidly evolving situation. There was concern about tensions between what they were able to offer in line with the protocols and what actual clinical needs were. And also reflections, particularly from some of the senior people, about how hard it was in the middle of the pandemic to evaluate what they were doing, working out whether they were doing the right thing. But on balance, they were proud of the resilience of the staff. It had been phenomenal, said one paramedic. And also the fact that when things had to get done, they got done. Maybe a positive to come out of the whole situation. Decisions just got made quicker, as one locality manager said. So overall, what we've explored was how implementing these new triage protocols in response to the pandemic was something that had to be actively managed by a range of frontline staff. It was work in itself. And this is a story which they really wanted told. And I think what the pandemic revealed was sort of what you might call a heightened version of some of the challenges which are really very familiar to anyone who's studied emergency ambulance services. So this question of how you balance protocols which tend to be very risk adverse with clinical judgment, sensitivity of responding to the actual situation, the challenges of dealing with unpredictable demand. There's always going to be peaks and troughs. And also the challenge of getting the interaction right with the other healthcare providers. But there were a couple of things which I think were very, very particular to this situation of the pandemic. So one is how strong this story was of the emotional impact, and particularly the health risks which came from just doing the job. Knowing there was a high risk of picking up an infection which could kill you, and also the mental health risks as well. And the other one was the fact it was such a situation of uncertainty and constant change, extremely hard to adapt to. So there's a number of different outputs going to be coming from the TRIM study. Already we've got one paper out, if you are interested in this, looking at call triage volumes and so on. We're going to be reporting other aspects of the study later this year. Thanks to the UK RI and Department of Health and Social Care COVID-19 Rapid Response Rolling Call, and to the whole study team, who are many, many people, some of whom named on that slide there. If you want any more information, please feel free to get in touch with me, a.m.porter@swansea.ac.uk. On Twitter, I am Swansea Alison. Easy to find. Thank you very much for listening.